Okay, well, welcome to this session of slide review. We've got a number of smooth muscle and other mesenchymal lesions from the uterus to look at today on digital slides. So this first one was just kind of to experiment and to let you see what it was like to move the slides. Based on your experiences with tumors of this sort, what do you think is the diagnosis in this case, Anosha? You'll have to unmute yourself.
Okay, so I think it's a leiomyoma.
Yes, it has all those sharp features of circumscription.
Yes.
It does have a little bit of added cellularity, of course, and we looked at that on high magnification. But small size, and we could check for mitoses and so forth, but we don't really see those here. Okay, so let's, first, I should also apologize that not all of the links were working. I don't know exactly why that was the case, but let's look at another example of a smooth muscle tumor. This one from the skin. And let's see, let me turn the mouse back over here to Ellen. Well, let's see. Let me turn it over here to Philip. So you can explore this one. It's obviously from the skin, so not a uterine lesion, but the same principles apply.
Okay, so this is underneath the skin, and I'm trying to move it. Okay, it's got a little lag. We have this like pretty well circumscribed lesion. There's a lot of vasculature inside of the lesion and kind of around the lesion, and in some places, like through here, I don't know if you can see where my mouse is.
Yep.
You could almost, maybe not quite that well here, but you can almost hallucinate that there's like a gap here. Well, there is a gap, but you can, in some places, almost see little lining cells. And the cells in the lesion are pretty bland. There weren't really any mites. There are no like bizarre features. So this looks like a leiomyoma, and it almost looks like it's in a vessel.
Yeah, it's certainly very vascular. And whoops, I'm going to take back over control and go back here to our lesion. And it's quite cellular. And as you know, obviously, these tumors in the skin can be quite painful. And it's probably this vascular nature of them that makes them as painful as they are when they're in the skin. Okay, let's move down here to another smooth muscle tumor here. This is, I'm not sure this is one that I gave you, but maybe we could just ask Eleanor to give some thoughts as we look through this one. So what do you think at low power, Eleanor? You're unmuted. Okay, good.
Yep. So at low power, it looks like it's pretty well circumscribed. It's not, at least the center portion really isn't all that cellular. It's got more of just like a necrotic sort of hyalinized debris impression to it. And then, so I'm not concerned about it being malignant. Overall, it just looks like a fibrous material proliferation. There are some more cellular areas that line it, but once again, they just kind of have like a myofibroblastic smooth muscle proliferation sense to them. So this looks like another leiomyoma.
Yeah. So what's different from this kind of necrosis that we see here and the kind of necrosis we might be looking for in a leiomyosarcoma?
There should be reactive change.
Yeah, there's often a reactive area around the necrosis, and there's sort of single necrotic cells. There's a transition zone there. This is what you would term hyaline necrosis, or maybe infarct-like necrosis. It also probably is associated with some calcification here, as you can see.
Mhm.
So yeah, not a problem diagnostically, but it is important to sort of have a nice, clear picture of what hyaline necrosis looks like. And I think this is as nice an example as I could find on a digital slide for us to look at. Okay, let's look at another case here. Rufe, you want to unmute your microscope and talk about this lesion? And I'll even give you control of the slide, Rufe. Okay, where are you? Wait, I don't see you. I guess I'll have to drive. Tell me what tell me what you'd like to look at here. Wait, we lost Rufe. I guess I can't ask you to do anything. Carlos, let's have you do it. I'll give you the mouse here, and you can drive this lesion.
Okay, let me. Okay, so in this lesion, we can see areas that are a little bit hypercellular, and some of them are more hypocellular. The hypercellular areas, we can see some bizarre nuclei, but I don't see much areas of necrosis at this power. Also, I see the blood vessels that are, well, they have this kind of thick blood vessel appearance in the around. And also, yeah, I think this one, I don't see much either necrosis or mitosis, but this is like atypia. So this may be a leiomyoma with bizarre nuclei.
Yeah, it's very good. And I'll take the mouse back here. You very easily recognize the atypia that is present, and that's manifested even at low power as you see these splotchy areas of nuclear prominence and cellularity, and then other areas that are less cellular. So one of the criteria for malignancy, of course, in smooth muscle tumors in the uterus is cellularity and some degree of atypia. And so this is a lesion that, you know, certainly takes that to the nth degree if we look at an area like this, and we see these very large and bizarre nuclei, as you see here. And, you know, you sort of look at things like this and you go, is that a mitotic figure, or those sorts of things. And so it can be very difficult sometimes to evaluate for the presence or absence of mitoses sometimes, because a lot of times these very atypical nuclei look like they are mitotic figures. And so what's one stain or one approach that you might take to sort that out? Carlos?
Yes, so we can use KI67.
Yeah.
And also we can use P53.
Okay.
And well, if we don't fulfill the criteria for leiomyosarcoma, but we have a increase in this stain, we can call it a malignancy of uncertain malignant potential.
Yes, very good. So yeah, another stain that may be useful, of course, is phosphohistone 3,
Oh, yes.
which would decorate a cell that was actually in mitosis with exposure of that, the antigens of phosphohistone 3. And so you brought up the P16 and P53 mutations or manifestations of that. And some people have advocated using those as criteria to identify lesions which had some but not all the features of potential malignancy. And so in certain situations, if you have a lesion like this with cellularity and atypia but not mitotic activity, but if you did have a mutation in P16 or in P53, you might then move it into that category of smooth muscle tumor of uncertain malignant potential, warranting a little closer follow-up. So again, going back to low power, the thing that we're missing here is mitotic activity or necrosis. And so this is an important image to see that you can have this kind of atypia, even areas of very bizarre cells and variable cellularity. We could look at this other area over here. It's not moving quite as normal, as quickly as normal. As we looked at this area over here, again, we'd see this vesicular growth. And this lesion is showing this sort of clonal characteristic with these nodular areas like this, and then other areas that we saw, like say down here and so forth, that are characteristic of some sort of clonal growth. So this would be an important one to maybe look at doing those kind of stains on. Comments or questions on that one? Okay, well, let's move forward onto the next case. Jordan, I'm going to give you control on this case now.
Okay.
So take it away and teach us what you see here.
Okay. Well, lots of dark blue kind of spread throughout here. There are some areas without our dark basophilic cells. I'm going to zoom in a little bit. Can't really get a good impression other than they're blue at low power. Let's see here. Okay, so even from this power, I'm still getting the impression of some spindle-shaped cells, kind of a vesicular architecture. From here, it looks like there might be a little nuclear pleomorphism. I'm going to zoom in a little bit more to make sure. Okay, so I'm not sure if this is going to be the quote worst looking area on this slide, but looks like here, yeah, there's some nuclear pleomorphism. Some of the cells look a little atypical. Looks like we have some hyperchromasia. Trying to see if I see a lot of mitotic activity. I don't think I can just yet. But this looks a lot more cellular, I think, than the other cases we've looked at so far. Let's see here. I'm definitely thinking this looks more malignant than the other cases as well. So I'm trying to move it over so I can look at a different area. But right now I'm thinking leiomyosarcoma, just based on the features we talked about. These nuclei, I don't like the way those look. Those are a lot bigger. Definitely some atypia, like I said. Yeah, so that's what I'm thinking right now, at least.
So what other criteria would help you to maybe confirm that diagnosis? Talked about
okay, well,
mitotic figures.
I didn't, maybe I zoomed in too fast. I didn't really see a lot of like tumor cell necrosis, but that's something I'd be looking for.
Okay, so let's go back out to low power here and tell us if you think we've got some tumor cell necrosis here. There in that lower left, you've got an area that's obviously sort of pink and hemorrhagic and so forth.
Yes.
And has a few scattered cells in.
Yes. So that looks necrotic.
Okay. There's one other feature that can be useful. I'm going to resume control here.
Okay.
And that is your margin. And so seeing an infiltrative invasive margin can also be helpful in defining malignancy. But up here, we see sort of both. We see this sort of pushing invasive character to it, and we see this area right here, which I think we could nicely classify as tumoral necrosis, tumor cell necrosis, because we've got histiocytes mixed in with this, and then you've got viable tumor down here that is sort of fading into a very eosinophilic necrotic tumor. So that's, I think, a nice illustration of what tumor cell necrosis looks like compared to that hyaline necrotic change that we saw. And then we have at least the suggestion here in the terms of the way this is bulging and pushing into things, that it's probably got an infiltrative margin. This mouse is doing funny things. Okay, well, we'll fade to the next case. All right, Beth, unmute your microphone there, Beth, and see what you can.
Hi, I'm using Eleanor's microphone because I don't have one.
Oh, okay. All right. So I'm going to drive this one, and you can just tell me where to go. You can annotate if you want. There's an annotate button. And so you can click on that and tell me what you'd like to look at. But I'll keep control for now.
Okay. So from low power, it looks like we see kind of two discrete morphologies. So kind of one that's highly cellular and looks kind of like it has a spindle shape from like low power. And then on the left side, looks more of like a, yeah. And then on higher power, kind of looks the same. So here we see more spindle shapes that are in that fascicular pattern. And then it looks like we can spot mitosis from this power already.
Wow, you're sharp.
Oh, well, it does look like it.
Yeah, no, I think you're right. They're here. It's just I'm kind of squinting into the screen here, but yeah, you're right. There's some things that look very good for mitoses in here, and maybe some single cell necrosis. So what else could give you this cellular kind of appearance, contrasting with the myometrium here? So what might you have to consider in your differential diagnosis for this lesion?
Like an endometrial stromal tumor?
Yeah, exactly. And would you be thinking a high-grade tumor or low-grade stromal sarcoma?
High grade?
Okay, could be high-grade or a low-grade, either one. Usually, maybe with the pleomorphism here, you'd be thinking more high-grade than low-grade, but it's not very pronounced pleomorphism. And how would you distinguish those two, aside from the fascicular growth that you've talked about, or anything else that would help you or convince you?
Stains, but I think also there was something about blood vessel thickness. I don't know if that was this one or not. Where endometrial stromal tumors have like a thickened blood vessel.
Actually, it's the reverse. Endometrial stromal tumors have very minimal, very delicate capillary type of lesions and don't tend to have thick blood vessels, whereas my smooth muscle tumors do tend to have more large and variable sized vessels. And this does not have very, very much, which I think makes this a very challenging case because of that reason, because the vasculature here is not particularly like that we saw in the other smooth muscle tumors. Then you mentioned markers. Which markers would be helpful in differentiating the two?
CD10.
Okay, you'd expect the stromal tumors to stain with CD10.
And then ERPR.
That may be helpful, but if you stain very many endometrial cancers, you'll note that the fair number of the smooth muscle cells in those lesions will also be positive with the hormone markers. So that
then,
may not be quite as reliable.
So what do we do, Desmond or SMA?
Yeah, Desmond or a H-Cal-Desmond marker would be fairly specific. Smooth muscle actin is not particularly specific enough to be very useful for most smooth muscle tumors in this situation. So we didn't see necrosis in this case. What about the diagnosis of smooth muscle tumor of uncertain malignant potential? Where would we distinguish, or what would be our cutoffs in differentiating this lesion from leiomyosarcoma?
Would it be the number of mitoses per high power field?
Yes, it would be. Do you know the number?
Not off the top of my head, no.
Yeah, so, and I usually have to look those up, but I think the answer to that question is that leiomyosarcomas usually have more than 15 mitoses per 10 high power fields. And so if in the absence of necrosis, but with cellularity, some atypia, and that number of mitoses, you could make the diagnosis of leiomyosarcoma in this case. But if you had less than 15, say you only had 10, then you would probably put it into that smooth muscle tumor of uncertain malignant potential category. And what does that mean clinically? What are they going to do with that diagnosis?
Treatment would change, like aggressive treatment, I guess.
Yeah, so with a sarcoma, they will potentially give adjuvant treatment. They'll follow more closely. If you have a smooth muscle tumor of uncertain potential, they're unlikely to use any chemotherapy agents or radiation, but they may follow up on that patient more frequently to look for recurrence or metastasis or evidence of spread. So there is a significant difference in the follow-up for those patients. Any other comments or questions on this case?
No.
Yeah, I think it illustrates nicely that differential between endometrial stromal sarcoma and leiomyoma or leiomyosarcoma, and also the differential between uncertain malignant potential versus leiomyosarcoma. All right, so let's go to another tumor down here just to keep practicing here. Let's see, who have I not picked on here? Eleanor, since your microphone's already in use, why don't you go ahead and talk about this lesion?
Okay. So this one, in terms of the one Beth just looked at, is got a similar low power impression. It's not quite as dark, but that just might be staining. There seems to be a ring of sort of lighter pink to white, tissue around it, and then some areas that look pretty hypocellular adjacent to it, and then on the other side of it, very hypercellular. So it looks like we've got tumor adjacent to necrotic tissue, and then the lesion has that fascicular pattern again, that sort of lamellated herringbone impression to it from further away. And we also see some really thick-walled vessels from low power that are just kind of strewn about in those unusual fasciculated cells.
Yeah.
And even from here, we can see that probably some of these nucleoli are really odd and dark and enlarged, or nuclei, excuse me. So we can see that there's some already pretty bizarre features, some mitosis, and overall it doesn't look super friendly. So what is that weird little spotty stuff in the corner?
Good question. What is that? Maybe inflammatory cells there. Yeah.
They are arranged sort of funny there, but again, depending on, I'm not sure the location of this, like where it was excised from. I guess I could look at the info tab because
I think we're in the uterus here.
uterus
Let's
again.
just check here.
So
oh no, it says skin. So
skin. Oh, okay. So I wouldn't be considering like an endometrial stromal sarcoma necessarily as a differential. But a stump could be, again, on the differential for this, but based on the morphologic similarities and the presence of the necrosis and mitosis, I would lean to more leiomyosarcoma.
Yeah, and why would you not think just leiomyoma with bizarre nuclei? Because certainly you have bizarre nuclei here, like these. I mean, this is not all that different than the case Carlos talked about in terms of the nuclear morphology, right?
Yeah, so the degree of mitosis, the necrosis is quite like frank, and there's a decent amount of it.
Yeah.
And then also the level of inflammatory cell infiltrate, now that I'm thinking about it more, there's quite a few inflammatory cells in there, and that sort of like stromal reaction to me leads me to more something that's more high grade and can be called leiomyosarcoma rather than a stump.
Yeah. Now this margin here between the tumor and the necrosis is a little bit atypical in the sense that, you know, there is sort of a transition here where it doesn't look very atypical. It looks more healing kind of thing. So you might be misled into thinking, well, could this just be, you know, infarct-related necrosis or something like that? But I think I would still qualify this as tumor cell necrosis just because it has so much nuclear remnants in this tissue that you can almost still see the ghosts of the cells in here. And so I think this is still tumor cell necrosis that would push you into the either stump or leiomyosarcoma based on your mitotic count. But with necrosis, bizarre nuclei, hypercellularity, you've got 3 criteria right there. And so you don't need very many mitoses to be found in order to feel comfortable making this diagnosis leiomyosarcoma. Okay, let's go on to one more. Yes, good job. So here's a tumor that obviously has some lymphoid tissue around it and maybe is involving fat and so forth. And so what do you see at low power here? Let's see, who hasn't talked? Philip, you want to talk? Let me let you run this one too with your mouse.
All right. I think I'm on a bad lag. I'm still looking at the last tumor. Okay, here we are. So, I mean, there is some necrosis over here, kind of a like pretty distinct boundary between viable tumor and necrosis. Let's see if it'll let me zoom in or not.
There you go, dive.
Okay. And I mean, there is kind of some spindle. It's a little spindly. It's not that spindly at this power. Let's see if I can go in any further. Yeah, so it's very spindly. And there is some kind of nuclear pleomorphism floating through here. I think I see a couple mitotic figures. I want to go over to the necrosis because when I was going in, it looked like it might be a little more hyaline than coagulative, but it was hard to tell. And it's in a lymph node?
Could be. That's lymphoid tissue there, isn't it?
Yeah. Okay, this is a little more hyalinized. It doesn't look quite as necrotic as I thought it did. Yeah, I'm just having a hard time figuring out what's going on because of the long lag between when I move things and when I'm seeing it.
Yeah, so certainly by virtue of the location involving soft tissue and abutting lymph nodes and so forth, we would think
This probably isn't benign.
metastatic or a direct extension of a malignancy.
I'll give you your mouse back.
Okay. Okay. Back to our tumor here. Yeah, so this is, I think, cellular enough, and location-wise, you'd be comfortable calling this leiomyosarcoma, even though that necrosis there is not the kind of tumoral necrosis that you might like to see. You might have had that. You might have other better areas, maybe down here. Let's just see if we got kind of tumor type necrosis. Well, those are inflammatory cells again still, so probably more likely just the part of the residual node remaining. All right, so let's come down here and take a look at this case here. Anosha, let me have you talk about this case, and I'll let you try to run the slides and talk about what you see here.
Huh? So I'm seeing there are multiple islands of blue cells with an infiltrative pattern. Can I? I'm trying to control it. Am I doing it?
It's not moving.
Okay.
I can see you moving the mouse though.
Yes. So what to do? How to move it? I'm moving the mouse, but nothing is moving.
All right. Well, let me control it then here, and we will. You can go ahead and describe, and I'll try to move what you say.
Yeah. So all I'm seeing are multiple islands of blue cells, which have kind of an infiltrative or a serpiginous pattern.
Yes.
And there is some vasculature which is very very interspersed or mixed with that, with the blue cells.
Yeah.
And,
See some vasculature there. And how would you characterize the vascular? Large, small, capillary, arterial?
It's like it's very delicate, and it looks like it's capillary.
Yeah.
Okay. So yeah, and if we go down further, I'm seeing there are uniform spindle-shaped cells. I cannot appreciate mitosis, and I cannot appreciate any nuclear pleomorphism either. So they are very uniform. There's not much atypia. Maybe rare mitosis somewhere. I cannot appreciate. Yeah, I can see one.
Yeah. Yeah, it's difficult on digital slides to find the mitotic figures, maybe, and be certain that that's what they are because of the scanning magnification at which it was scanned. But you can usually get an idea if there's very many. And
Yeah.
this is, do you see how this is different than, say, the one that Beth was describing that was similarly kind of dense blue without necrosis and so forth?
Yeah, I can appreciate much more of a delicate vasculature in between, and the cells are more kind of epithelioid.
Yeah, that's a very, very important feature to be able to see with your H&E eyes, to sense that difference in how the architecture is just subtly different from that other case, and contrasting this kind of vasculature versus the vasculature that you see over here, which is still a vascular lesion, but the way the cells and the vessels are interspersed is quite different.
Yeah.
And so that's an important distinction. So based on what you're seeing here and the pattern of infiltration, what is the differential consideration that you would have for this lesion?
So my top differential will be an endometrial stromal sarcoma, and after that will be PEComa. And
Okay.
I don't think it looks like a leiomyosarc, or it can be that category when we call it undetermined undetermined category. But I will lean more towards endometrial stromal sarcoma.
Okay, very good. I think there's one other consideration that needs to be mentioned here. It's less common than endometrial stromal sarcoma, but it still has this pattern of kind of migratory tongues and nests of cells that move through the myometrium, and oftentimes maybe will appear to be within or in between fascicles of the smooth muscle, or between and involving vessels, and that's so-called intravascular leiomyomatosis. Can have this kind of an appearance, and that will usually have again slightly more cellular than the surrounding myometrium, but will look much more bland and won't have quite the same uniform capillary pattern. So I did a video recently on that entity as well, and you can look at that after a conference another time at your leisure. So yes, endometrial stromal sarcomas. And how do we grade endometrial stromal sarcomas? What are the key features in terms of grading?
Maybe we look at the pleomorphism and atypia, but I'm not sure.
Yeah, so being able to recognize them as you know, mitotically proliferative and having this sort of a pattern, this is very typical for the pattern of the low-grade tumors, as to have these tongues and nests. Higher grade tumors will, they sort of lose this architecture, and they have a much more mass forming and displacing kind of growth pattern, as well as less well differentiated type of appearance. And so it can be a little bit challenging in that regard. You can also, in these tumors, from time to time, see sex cord elements or see other areas of differentiation that can make these quite complex and challenging. At the low end of the stromal tumors is what's called the stromal nodule. And that does not have this invasive infiltrative appearance that we see here. It's generally confined to the endometrium. You know, it may be several centimeters in size. It may sort of indent the myometrium, but it will not have this invasive pattern of growth and extension outward into the you know, adnexy and so forth. So that's another important lesion to be familiar with. Okay, well, let's go on to one additional thing that enters into the differential here. Rufe got off of the boat for some other reason. Is there anyone else who'd like to do a second case? Okay, well, nobody's raising their hand, so we'll just sort of go along. Now, this is a skin tumor, and it obviously has an infiltrative pattern, but because we can see a similar tumor in the endometrium or in the uterus, I'm using this as an example for your educational benefit. So we notice at low power that this doesn't really have a fascicular growth pattern. It does have a vaguely nesting or some sort of an architectural appearance of maybe some streaming, but we see that it does have a mesenchymal appearance, and it has vessels of varying sizes in it, even here as it goes through the dermis. We can see there's a degree of atypia associated with this lesion, although not the degree that we saw with most of those sarcomatous lesions. And this is a lesion that can occur in both benign and clearly malignant constructs. And so you may see variable kinds of atypia. It's also a tumor that has potentially late recurrences. So we're talking about the perivascular epithelioid cell tumors. Here you can see that this tends to have a slightly cleared cytoplasmic appearance. It's slightly granular, but cleared and a little bit pale pink in terms of pattern. So just to review, of course, you're aware, what are the immunohistochemical findings that you expect to see in this tumor? This is a board question, so who's going to take their boards next? Carlos.
Yes.
Carlos, what do you expect to see in terms of immunohistochemistry for these perivascular epithelioid cell tumors, or PEComas?
So we expect to see HMB45 positive, also melanA as S100, and desmin, and CD117.
Yeah, very good. So that's a very uncommon combination of markers, is it not?
Yes, yes.
Yeah, so you've got melanocytic markers, the HMB45, melanA, and you can see MITF as well. And then you've got the myeloid markers. So this is, in one sense, this is what's now being called a polyphenotypic tumor. Whether that's truly what we end up calling them in the long run, but it's a category of lesions now that have this seemingly schizophrenic or biphenotypic expression of markers. Now, we've had a couple of cases recently that have presented and been discussed in tumor boards, and some of you may have been present for some of those. Does anyone have a particular recollection as to the presentation that prompted their consideration at tumor board? I don't know, maybe it was Doa or Philip, maybe one is discussed in when you were doing GYN tumor board recently. Do you recall?
I don't think it was me, no.
Okay. Well, so the reason they came up is because they had recurred. And in one case, it was about 3 years post-surgery. In one case, I think it was 5 or 6 years post the initial surgery. And so that's an important consideration, is that they may recur locally or regionally and present with recurrent challenges in terms of operative management. And partly that's because we have a difficult time predicting their behavior based on purely on the morphology and the histochemical markers that we have. Here's another example of this lesion. This one is from the uterus and is a case that was at least initially classified as malignant. And perhaps we can see here, this is a little bit different appearance than we would expect with the smooth muscle tumors. But it does bring up a differential with the smooth muscle tumors of a particular type, and that is with the epithelioid smooth muscle tumors. Most of the ones that we've looked at today have been spindle cell smooth muscle tumors, which are clearly the most common ones. But there is a variant of smooth muscle tumors that can be quite epithelioid. And the criteria for malignancy in those lesions is, it's like the bar got lowered because of the epithelioid morphology. And so you have to be careful about those lesions. And they come into the differential with PEComa. As you can see sort of here, you've got these sort of little epithelioid clusters of cells that could very easily be smooth muscle cells that have an epithelioid appearance. And those epithelioid smooth muscle tumors, they can have some cytokeratin markers, and as well as the smooth muscle marker. So in another sense, they're biphenotypic as well. But the mitotic count required for an epithelioid tumor is considerably lower. And so anything with 4 or more mitoses per 10 high power field and a very moderate or worse degree of cytologic atypia would fall into the category of being an epithelioid leiomyosarcoma. So in our differential considerations, we want to include the immunohistochemical markers that are going to allow us to differentiate PEComa from smooth muscle tumors, both the epithelioid as well as the more conventional leiomyosarcoma type lesions. In terms of criteria for malignancy with PEComa, again, its behavior is probably the most important one. Some of the same sorts of features, nuclear pleomorphism, atypia, mitotic figures have been used as the criteria. And I would not commit those to memory, but would rather reference the most up-to-date texts when making the fine distinctions on those lesions. So a nice example here today of that lesion, and you can see the nuclear atypia in this lesion as well. So I'm sorry Do is not on. I think she was going to follow up with some of those prior and recently resected PEComas to load those up here onto Path Presenter as well, so we can share those later. So those are the cases. I guess we have a minute or two. We can do one more lesion here, just for comparison. Anybody want to tackle this one as a second one?
I can do it.
Okay. Do you want me to give you the mouse?
Yes, please.
Okay. All yours, Beth.
I don't think it's moving.
It's not moving?
No.
All right, I'll take it back.
Okay.
We tried.
Okay, so where do you want to go? Here, 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 here.
Let's go to the right of the screen where there's more blue.
All right. What did the low power image sort of make you think about?
So they look kind of nested.
Yeah. So is it multiple leiomyomas or is it something else?
I don't think it's multiple leiomyomas. I'm thinking maybe either endometrial stromal tumor or a...
Kind of slow. There we go. Now it's coming into focus.
I was thinking either endometrial stromal tumor or a PEComa.
Okay. Is it spindled or epithelioid?
It looks more spindled.
Okay.
It doesn't look like there is much necrosis when we look from low power. And then I don't see a lot of mitotic activity.
Yeah, not too much in that way. Let's go to another area and just sort of compare. Let's say go over to here. What do we see here?
Myxoid change.
Yeah.
So like possibly a myxoid leiomyoma.
Yeah, so we didn't talk about the myxoid variants, and those can be very challenging. Fortunately, they're not very common. You can have both hydropic as well as myxoid leiomyomas, but you can also get this sort of clustered and tubule-like structures that almost, you know, if you were to imagine a little bit, this could almost look like little sex cord elements to a degree here. So little corded and nested areas like this, you'd want to include potentially sex cord differentiation in your thought processes as well. And that can occur with either uterine tumor resembling sex cord stromal tumor, which is another entity that's quite unusual. We haven't copied that into today's group, or it can occur in endometrial stromal sarcoma. So that's another little interesting variant there. And then up here, what do we think here?
So these kind of look almost the same as the ones that we saw. So still kind of the same morphology. It looks like they have clear cytoplasm and myxoid change with a very low rate of mitosis.
Yeah. Now, we haven't talked about the vasculature here. Let's see if there's another area up here. We can see if there's more clues up here. In these bluer areas, and here you get a little bit more of this sort of corded differentiation here as well. So a tumor that's sort of nodular, blue cellularity, and has this corded or reticulated and slightly myxoid pattern. Our differential would include endometrial stromal sarcoma with potentially sex cord differentiation, smooth muscle tumors with sex cord or uterine tumor with sex cord differentiation, multiple leiomyomas with myxoid change, PEComa you've mentioned, although the reticulated pattern of growth would be quite unusual for that lesion, as far as I know. Anything I've left out?
No.
Yeah, I think this is a case where your markers would be useful to sort of elucidate that. So which markers would you want to do, Beth?
CD10.
Okay.
Desmond.
Desmond.
The Cal Desmond.
Okay. Now what about for these sex cord stromal elements? Or potentially sex cord stromal elements?
Beta-catenin.
Beta-catenin could be helpful. Calretinin or inhibin could also be helpful. And even cytokeratins might be useful to see if you're getting any cytokeratin labeling with those as well. So I think as this case was entered as an endometrial stromal sarcoma, but it's a little bit different than the other one we looked at. It does have sort of the nodular growth, but it's a very different pattern of growth because at the periphery of these nests, you've got the more smooth muscle differentiation. And that occasionally does happen with endometrial stromal sarcoma, is that you can get a peripheral area with smooth muscle differentiation, but then these more cellular areas will not have that. This does not have quite the same vascular change or pattern that Anosha described in her case, but it does have this somewhat unique pattern of trabecular or sex cord-like growth pattern that has been described in endometrial stromal sarcomas as well. So it's a nice contrast to the other cases that we've looked at so far today. Well, we're at the top of the hour, and you guys have done a great job in discussing these cases and sort of leading us through them. Any final comments or questions? Well, if not, then we'll sort of wrap it up at this point and wish you all a good afternoon. Thanks for joining me. It's been a lot of fun to see some of the strengths and some of the weaknesses in this modality, but we will continue to try to work on things in the future. Thank you very much, and have a good afternoon. All right.
Thank you.
Thank you.
Thank you.
Thank you.